the cystic duct. And so this is a nice case of acute cholecystitis, just uncomplicated. But I liked all those signs that we saw on that CT. Does anyone have any questions about this case? Okay, we'll move on. Here is our next case. This is a 30-year-old male who came into the ER with just some right upper quadrant pain. I wonder if this is projecting well and if you can tell what is going on in this case. Does anybody know? So we're just doing kind of liver gallbladder cases just for now. What do we think about this gallbladder?
Okay. Hello? Hello?
Hi.
Yeah. Okay, I think the gallbladder has a thickened wall.
Yes, you're right. Exactly. Okay, perfect.
And can you scroll through a bit? I see a hyperdense. Okay. So basically, it's gallbladder wall, diffuse gallbladder wall thickening.
Yes.
I can't see any stones.
Correct. Okay, no calcified stones, right? I mean, what else? So you're correct. You're talking about the gallbladder walls are diffusely thickened. It's markedly thickened. Yeah. But it's not distended, and like you said, there's not stones. What else, what are the other findings here? They're in the it's in the chat. Somebody's given us a hint in the chat. In the yes, I see periportal cuffing and not full gallbladder. And then they say hepatitis, and that's exactly what this is.
Yes.
So
Yes.
good job, and thank you for speaking up. Thank you for speaking up. You've got it exactly. So is this acute cholecystitis? That's what this comes down to.
Well, I think it's a reaction. It's a reactionary wall thickening from the inflammation in the liver.
Exactly. Good job. Yeah, perfect. So the point is, in this case, do you see how different this case is to the other case? This gallbladder is not distended. There's not really a lot of fat change, a lot of inflammation around the gallbladder itself. This is just primarily within the gallbladder wall. The gallbladder is not tensile, not hydropic. There's nothing in the gallbladder. It's not filled with stones. And you notice too, this is a really important feature here, did you notice the hypoattenuation around the portal system? And it's on both sides of the portal system, meaning this is periportal edema, and it's not just some, let's say, biliary dilation, like the biliary duct in the portal triad is not just dilated, it's on both sides of the vein. And so that's edema. And this is simply hepatitis. And you get this is a very classic appearance of the gallbladder in the setting of hepatitis. And so you don't want to see this and say, oh, this is acute cholecystitis. They need to have their gallbladder out. Go to the surgeon. It's not that. This is hepatitis, simply hepatitis. And so this is something that you want to just remember, this appearance of the gallbladder. It's very classic. And then you can give the diagnosis right away. If you ever see this, it's kind of like you see this appearance and you know exactly what it is. And this is just hepatitis. So good job. Thank you again for speaking up. All right, we will move on unless there are questions about this one. Okay, so now here, this is just kind of like a companion case. I just want to show you, this is an ultrasound. And here, what I want to show you is the really prominent periportal fat. So do we see these lines here surrounding the portal, around the portal triads? This is the periportal fat, and it's a very, very echogenic on ultrasound, on this ultrasound. You can see how it stands out really, really well on this background liver. So this is hepatitis on an ultrasound. So the periportal fat is really prominent. We say it's just prominent periportal fat or echogenic periportal fat. And this is just a finding of hepatitis. This was a different case. This was a 23-year-old woman who had gotten food poisoning at a restaurant. She had hepatitis, and her, of course, her liver enzymes were all really elevated. And this eventually did resolve, but just a companion case to that last one. This is how this would look on ultrasound. You'd just see very bright periportal fat.
Ya Allah.
Let's move on. Here is another case. This is a gallbladder or biliary case. And let me just open this up here. Okay. So what do we think about this CT? Does anyone see the finding? And this is sort of hard because you're not able to scroll through it, but we're talking about the gallbladder again. Okay, so here is our coronal CT. I'm just going to go through the gallbladder. Do we see anything in the gallbladder here? What do we think? I'll stop on this image. Does anybody know what's going on? All right, here we go again. Okay. I see in the chat stones in gallbladder and common bile duct and in left kidney. Wow, yes, you saw all the findings. That's great. So yes, you got it. So here I'll just point it out. Okay, so here is the gallbladder. Notice in this gallbladder, the fat around the gallbladder is really clean. This is not an inflamed gallbladder. This is just cholelithiasis, basically. Here's the stones right here, calcified stones on CT. So we can see those. And then here, following the common bile duct, here's common bile duct coming down to the duodenum at the ampulla. You can see that there are some stones right here at the ampulla. So cholelithiasis and choledocholithiasis on this case, but no evidence of acute cholecystitis. Great. And we have left renal stones. Yep, left nephrolithiasis here. And a cyst, of course, on our kidney. And some stones on the right as well. So calcs, stones everywhere. Good job. Okay, so switching gears. I want to show you this case. We have let's just focus on this ultrasound for now. So here we are showing at the level of the pancreas. Does anybody see what the finding is here? Here's our ultrasound pictures. This is a 64-year-old female, and they've just got some upper abdominal pain.
Okay. There's more of focal enlargement of the head and partly body of the pancreas.
Great.
And then this area appears hypoechoic.
Yes.
On
Excellent.
ultrasound.
Yes, excellent. There's a hypoechoic mass, apparent mass in the pancreatic head and neck, just like you said. Excellent. Okay. So then, of course, the next step would be to get the CT. And then let me pull that over to my main screen here. There's a lot of arrows on here. Okay. So let me just get rid of some of these arrows. Okay, so we get the CT. I'm going to move some of these measurements out of the way. Okay. So what do we think now that we look at the CT? What are some of our considerations?
Considerations will include a CA head of pancreas. It could also be a focal pancreatitis.
Great. Okay, good. Excellent. So we're thinking, could it be a cancer? Could it just be pancreatitis, right? Because typically our most common pancreatic cancer, adenocarcinoma, how would that look? So our classic adenocarcinoma of the pancreas is going to be hypoattenuating, hypoenhancing, right? And here we don't really see that necessarily, but we definitely see something's wrong. There's mass-like enlargement of the pancreatic head. It's also resulting in biliary dilation. Do you see this? See here, here's our common bile duct here, down here, our cystic duct is entering in. So above that, we just have our common, just called our common hepatic duct, but the left and right ducts are dilated, you can see. And you can also notice, just to give you another comparison, notice how this duct is dilated, and you see that the hypoattenuation is on only one side of the portal vein. So this is biliary dilation, right, as opposed to periportal edema. So that's just another good comparison, just compared to our last one, which had hypoattenuation on both sides of the portal vein. So here we have bil-dil. So this mass is actually resulting in biliary obstruction as well. Okay, so that worries us, right? We think something's obstructing the duct. This must be a cancer. This must be a mass. Well, they went in with EUS. They did an endoscopic ultrasound. They took a close look at this mass and they did biopsy it, and they did not get any evidence of malignancy. So this is indeed focal pancreatitis, and it looks a lot scarier than it is, but this patient was treated with steroids. Does anybody know what specific entity this is? If it resolved with steroid treatment. So this is a specific entity, a specific type of pancreatitis.
Recording in progress.
This is called IgG4 pancreatitis. I want to show you the follow-up. It's really interesting. And within a month and a half, this resolved. I mean, after treatment, of course, they were given steroids. Let me see if I can find the follow-up in June. Here we are. And I wonder, can I put these next to each other? Just to show you. So here we go. Let's look at this pancreas again now. Here we notice that the pancreatic head is much smaller. The lymph nodes, the reactive lymph nodes, maybe a couple of them are still there, but they were, rather than being metastatic nodes, they were just reactive nodes. So check it out. Our bil-dil, all of our biliary dilation has resolved, and our pancreatic head has gone down in size And so we do not need to have, this patient does not need a Whipple procedure, or, they don't need a surgery, they just need steroids. And that's a big, that's a very big difference in treatment, right? And so patients in the past have undergone major surgeries for this, and retrospectively, they could have been treated, they could have been managed with steroids. And so this is a really important diagnosis to know about, because some people, they could potentially go to surgery for this, and really they just need steroid treatment. So I will say on this case, initially, the radiologist was raising a lot of concern for a mass and a malignancy. And then that's why they do the endoscopic ultrasound. That's why they do the serum markers, and so that they can treat this patient appropriately. So this ended up resolving. It's a really neat case, and the biliary obstruction, of course, resolved. And that's an important thing too, is yes, you want to be worried about a mass if there's biliary obstruction, of course, worry about something really serious, but just really intense pancreatitis and inflammation can cause that buildup. Does anyone have any questions on this one? Okay.
Sorry, I have a question. Okay, okay. You favored focal pancreatitis over CA head of pancreas. Is it that it's typical of the CA head of pancreas not to enhance, or are there
Yes.
cases where it could enhance?
So most commonly, this is kind of just like a playing your odds essentially, but the most common type of pancreatic cancer is adenocarcinoma, and adenocarcinoma is hypoenhancing. That's its character. It does not enhance. It is not as enhancing as the pancreatic tissue. So if you see a hypoattenuating mass, and it can be infiltrative. It can, have ill-defined margins. Typically, that's the most common presentation. It's a hypoenhancing mass in the head of the pancreas, and that's adenocarcinoma. But there are other types of pancreatic cancer, such as neuroendocrine tumor, and neuroendocrine tumor is hyper-enhancing. So let me see. I think I do have a case of it. So let me just do a little bit of digging really quick, and I'll show you that type, so you can kind of see that there are enhancing masses too that you want to rule out, and that's why they do the EUS. That's why they go in and they take a look at it up close, and then get tissue. Let me see if I can find it. Well, this is a very small one. This is a very small cancer, or neuroendocrine tumor, basically. It's very small. This is not the most ideal example, but it's here. And it can look like the pancreatic tissue, or it can be more enhancing, than the pancreas, which makes it difficult. Let me see, do I have any other good examples of this? While I'm here, I'll just look quickly, and if I don't, we'll have to move on, but I've got a subtle case here of an adenocarcinoma. It's very subtle, though. I don't know that it'll be the best example. Okay, here. So this is a very subtle case, and this is why you've just got to have, when you look at the pancreas on CT, you've just got to slow down and really look at the pancreas, because you can save somebody's life if you find their cancer. So here is I'm just going to kind of scroll through the pancreas just to show you there's a little subtle hypoenhancement right here in the pancreatic body. And then that's also tricky, because usually you find it in the pancreatic head. But here you can see there's a subtle hypoenhancement in the pancreatic body. And this was actually a case that I was reading for lymphoma. It was for a lymphoma surveillance. And I incidentally found this hypoenhancing mass in the tail, or in the body. / tail of the pancreas. So this is what it classically looks like. It's hypoenhancing. And so that's just the most common presentation. But in our case, the whole pancreas looked to enhance very similarly throughout. It's just that the head of it was more prominent. And so because of that, you have to just have another, you just kind of have another thought in your mind of like, okay, if this is not a hypoenhancing mass, could it just be IgG4 disease, IgG4 pancreatitis, which is what our case ended up being. Did that answer your question? I went, you know.
Yeah, thank you. Thank you.
Mhm. So let's find our next case is, okay, this is a cool case. All right, this is a fun one. Okay, so here's another pancreatic case. So check this out. This patient, this is incidental. This patient was asymptomatic. Oops. So check this out. Now this is tricky if you're not scrolling like I am, but here's just the axial view. And then here's coronal. I love the coronal in this case. I think it really helps us. Here's our panc coming across here. And then here is our finding. Anyone have any ideas about what's going on? Asymptomatic patient? Any thoughts? Check out the coronal. So asymptomatic patient, there's no cancer markers, there's no nothing, no lab abnormality, basically. All right, here we have an answer in our chat. Good job. So, oh, and so somebody wanted to speak up? We've got our answer. You're correct. Good job. Annular head of the pancreas. Exactly. So this is a case of annular pancreas. So you can see that on the axial, it looks really like, you know, you sense there's something abnormal here. There's fullness down here around the duodenum. And you notice that the pancreatic tissue goes all the way around the duodenum. You can see here's the duodenum in the center and the pancreatic tissues on either side. And this is confirmed with the coronal, which is really neat. You can see that on the coronal, this perfect circle of the pancreatic tissue around the duodenum, right in the center. So it's a really cool case. There's two types of this. You can have it fully encircling the duodenum, or you can have it going partially around it. It's when it's an incomplete annular pancreas, it's said to have a crocodile jaw appearance. So kind of just, there's kind of like an angle going like this. It looks like a crocodile. That's what, kind of what I call it. And then what this is just a failure of the ventral bud. So this is during development. There's a failure during development. The ventral bud fails to rotate with the duodenum, and it just causes the duodenum to be encased with pancreatic tissue. So cool. Good job. This is a really neat case. This can be just completely asymptomatic, or this can cause, obstruction of the duodenum. And if it's going to cause obstruction of the duodenum, typically this is something that's discovered really early in life, when the patient has, outlet obstruction, basically a duodenal obstruction. Just a couple little bit more points on this. A third of the cases in adults are asymptomatic. It's typically incidental, just like we found it on this case. A couple symptoms that could happen, of course, abdominal pain, postprandial fullness. You could have vomiting and bleeding, potentially, GI bleeding from peptic ulcer disease. And then in kids, as I said, annular pancreas can be associated with other congenital abnormalities, or it could cause, a full-on obstruction. So cool. Any questions on this one? Okay, we'll move on. What is this one? Let's see. Okay, so cool. Here's another pancreatic case. I want to show you, let's first look on the right side of the screen here. What is going on in this case? Now, this is a non-contrast CT, and so it's a little bit trickier, but just in general, what's going on in this case? Anybody know what's just general, what would you just generally say about this pancreas here? So this is let's see, about a 40-year-old male who's presenting with really, really intense epigastric pain. Yes, good job, Olivia. This is Olivia in the chat. Mesenteric fat strandings around pancreas due to inflammation, infiltration. Exactly. This is a perfect answer, because this is a non-contrast exam. You can't be too specific. Who knows? Is there some infiltrative disease? Is this just inflammation? And in this case, this was just ended up being pancreatitis. So good job. This is just acute interstitial pancreatitis. There's no, it doesn't look, we can't talk too much about complication, right, on this because it's a non-con. But what would we be looking for? So we have the diagnosis of pancreatitis. What are some things that we need to, I see loss of the feathery pattern. Yes, that's great on the chat. Good job. Yeah. So what other things do we need to survey survey around for? We have acute pancreatitis. Okay. But that's not where we stop, right? We have to go into our secondary search and look closer at other structures around the pancreas, right? So what types of things do we want to make sure we don't have in the setting of pancreatitis? Gallstones, yes, good, yeah. So we were kind of trying to find the cause, right? What's the most common cause of pancreatitis? Well, gallstones. Alcohol is also another one we have to think about. What about complications of pancreatitis? Because this is a whole topic we could go on and on about, right? Because we've got different types. Good. Yes, I see in the chat. Thank you for everybody for chiming in. This is good. So we're talking about, we have to find complications like thrombosis, like pseudocysts, vessel thrombosis, pseudocysts. Everybody's putting this in. Good job. Exactly. So we're not done, right? When we have pancreatitis, oh, acute pancreatitis, moving on. No, we need to look at the vessels, right? Because what happens to veins? They thrombose. What happens to arteries? Pseudocyst. Good. We also need to look for a collection, potentially a collection, and we need to look for pancreatic necrosis. So is the pancreas fully enhancing, right? There's a whole other secondary search we've got to do when we have pancreatitis case, right? So let's just take a look at this case. So the first one I showed you on the right, this was in end of September, and then now we come back beginning of October, and while we don't see as much peripancreatic inflammatory change as we did on the prior, what do we have here? So what is the finding here? Splenic artery thrombosis. Good. Yes, exactly. Okay, what? Okay, or splenic. Sorry. Did you mean splenic artery, or did you? Oh, I'm sorry. It's not. It's not. When I leave it like this, it looks like splenic artery. I'm sorry. That's my fault. It's lower. Yes, it's the splenic vein. Yes, good. Sorry. That was my fault because I left it on a bad cut where it looks like it is the artery. So my fault. But no, here you can see the portosplenic confluence completely expanded and opacified. There's a filling defect and SMV, right? Because SMV comes up from the bowel, comes up, joins the splenic vein to become the portosplenic confluence and the portal vein, and all of that is thrombosed, expanded. So it looks like pretty acute, right? Expansile thrombus. So good job. Great, Olivia. You got it. You nailed it. Cool. Okay, so now that we're talking about pancreatitis and all the complications, I have a lot of cases I could show you just to kind of give you a run of what all can go on. So I'm gonna go to my pancreas folder really quick. Just bear with me. I want to show you a couple different things. We have just our everyday acute interstitial pancreatitis, which I did show you on that non-con, but let me see if I can show it to you here. The right one. Here. Here's another great case of just your everyday acute pancreatitis. It looks like, as was mentioned in the chat, we've got loss of our feathery normal kind of feathery contour of the pancreas. It looks engorged. There's peripancreatic edema, right? But there's nothing else going on. There's not splenic vein thrombosis or a fluid collection. We have maybe some hepatitis, maybe a little bit of reactive hepatitis there too. But so this is just our everyday simple pancreatitis. Let me go back to my folders and I'll show you here a case. This is a good case of, so within the pancreas, on this case, this is a different patient, but there is a little part that's not enhancing in the pancreas. And you have to think, okay, is that a mass? Because a pancreatic adenocarcinoma is hypoattenuating, or is this necrosis, meaning a part of the pancreas that's not getting perfused? This is so necrosis is another component of pancreatitis, right? And we need to make sure that during a pancreatitis event that our whole pancreas enhances the whole way, right? And so here in a part of the tail is not enhancing. So we need to keep an eye on that. So CT, and just to back up a little bit, so CT is not really how you diagnose acute pancreatitis, just initially off the bat, right? It's clinical. They've got really elevated lipase, they got all this pain, and it's a clinical diagnosis. And sometimes, and as we know, CT features of pancreatitis are delayed. So it's not keeping with the clinical scenario. It takes a little bit of time for the findings to show on the CT. So clinically it's diagnosed. But what CT is really good for is the complications of pancreatitis. So that's where we come in. That's where we do the CT. We can say, oh, they've got a collection. Oh, they have necrosis. And why is it important to say all those things? Well, because there's going to be an intervention done. People with a big pancreatic collection may have it drained. And if somebody has a really, really bad necrosis, it's not responding to treatment, they're not getting better, they may have that a necrosectomy, basically, that will surgically remove it. And so we need to, our role is to talk about complications and what do we need to do next. Okay, so in this case, I just want to show you, there's a little bit of necrosis here. Okay, so then what happens with that? Well, this ended up getting worse. And this is actually pretty tough to tell the enhancement on this case. Let's see. So here I think this is a much better demonstration of the necrosis, and it's kind of hard to tell because the whole thing looks abnormal. their whole thing, and so it's kind of hard to tell what's the problem. Okay, but look at this pancreas here, the pancreatic head. Look at how enhancing it is, and then you look at the body and the tail, and you can see it's not really enhancing. Maybe a central portion is enhancing. So this would be like a pancreatic. This would be very severe pancreatic necrosis. Okay, and so we need to look for, is there a collection to be drained? Hard to see here. It doesn't look like there's actually a really well-defined collection. But this is pancreatic necrosis. So this would be a necrotizing pancreatitis case. Do we see maybe the splenic vein looks a little bit attenuated, and there's probably thrombosis in there. So that's that example. Let me see. Here is what happens after a chronic, after we repeat pancreatitis over and over again. This is a chronic pancreatitis case. Let's see if I can get the one I want here. So chronic pancreatitis. Okay, here we have this beautifully demonstrated. So what do we see? Calcifications throughout the pancreas, a beaded, dilated pancreatic duct, pancreatic atrophy, loss of, that nice normal pancreas. This is a very atrophic. You can see how thin this is, all the calcifications throughout the pancreas, right? Because when you have pancreatitis, you prematurely release all the pancreatic enzymes that are used to digest food. They ended up digesting the pancreas itself, right? They damage the pancreatic tissue, and it causes it all to calcify and not function very well at all. So here's a chronic pancreatitis case. Okay, I see somebody's writing in the question, do you use modified score? I don't put a score. I don't use that. What I like is I use the Atlantic criteria. Maybe you've heard of this. It's how to classify pancreatitis. I don't put a score in, but I do like to use the Atlantic criteria, which separates pancreatitis into acute and necrotic pancreatitis. And then based on whether it's, interstitial pancreatitis and necrotic pancreatitis. And then what it puts it into is further categories of, is it acute, in the acute phase, or is it later? And that will tell you, that kind of tells you how you would name the collections. Do you have an acute necrotic collection or an acute fluid collection? And then after time goes by, right? If there's a time criteria. After 4 weeks, you don't call it acute collections anymore. You would be calling these walled off necrosis or a chronic or a pseudocyst, right? Because the pseudocyst takes time for that to form. And so that's more of a chronic or a later stage finding. So good. We went through a couple of those cases. Let me see if there's anything else in my pancreas. So after 4 weeks of symptoms, you start using different terminology. So here is another case. Let me just move some of these measurements here. So in this case, this is necrotic pancreatitis, right? Because we've lost the normal enhancement of the pancreas. So this is necrotizing pancreatitis. Only this patient has been in the hospital now for over 4 weeks, and they've had symptoms for over 4 weeks in the setting of pancreatic necrosis. So they have a collection now here, and it's walled off necrosis. This is what's called a WON, W-O-N, walled off necrosis. And this is how you refer to these collections after patients have had symptoms for longer than 4 weeks. So here is something that is, potentially drainable. But here is definitely necrosis in this case. And you can see the pancreatic head is more normally enhancing. Trying to see if there's any other complications in this case. Yeah, it looks like we have our splenic vein still. Okay, yeah. So yeah, this is what's called a WON, W-O-N, walled-off necrosis. Okay, there's our chronic pancreatitis case again. Let me get out of there. This was the original case. We've looked at that. Are there any questions about this? No, there's a lot of detail. Okay, can it be called a pseudocyst or WON? Okay, I see the question that you're asking here in the chat. Okay, so the difference in naming is whether or not there's presence of necrosis. Okay, so if the pancreas is all still enhancing and there's no necrosis, the fluid collection is called a pseudocyst after 4 weeks. Okay, if there's pancreatic necrosis, you wouldn't call it a pseudocyst anymore. You would call it a walled-off necrosis. And both of those terms, pseudocyst and walled-off necrosis, both of those terms are when you've got symptoms for longer than 4 weeks. Okay, so before that time, before 4 weeks, you wouldn't be saying those words, walled-off necrosis or pseudocyst. You'd be saying acute pancreatic collection, or acute necrotic collection. So the naming is a bit different. And again, it's called, I'm going to put it in the chat, it's called the Atlantic criteria. And I could, let's see, I could pull that up and just show you. Let me see if I can find it. I can share that with you. So here is a chart. Let's see if I can. One sec. There's one specific chart I'm looking for to show you. I need to go to the article. One second. And what I'm going to do is I'm going to paste the article right into the chat. If I can find it, here it is. This is the article, and it's definitely worth taking a look at if you haven't heard of this before. I'm going to move this article to my screen so I can just show you this chart. So this is the chart that I'm referring to. And basically, in a setting of acute pancreatitis, if you've got normal and pretty normal enhancement, the whole pancreas is getting, is lighting up basically, is enhancing. And you have pancreatitis, right? Because you have the inflammatory change and all that stuff. You call this interstitial edematous pancreatitis. If you don't see some of the pancreas is not enhancing. So like that one case I showed you with in the tail where there was part of the pancreas that was hypoenhancing, that's called necrotizing pancreatitis. Now notice that you have this dichotomy where you go either side, necrotizing or not, and then there's a time difference. So before 4 weeks and after 4 weeks on both. So now if you have a fluid collection in the setting of an interstitial edematous pancreatitis and it's before 4 weeks, it's called an acute pancreatic fluid collection. If it's after 4 weeks and you've had time to form the pseudocyst, That's what that's called at that time, is a pseudocyst. So you want to make sure that you're using the terms in the appropriate time setting. And that's something that's kind of, if you have that information, that's great, right? But if you have a necrotizing pancreatitis where part of the pancreas is not enhancing, you want to look at what time frame it is. If it's first 4 weeks, it's just called an acute necrotic collection. If it's after 4 weeks, it's called a walled off necrosis, or a WAN. Okay, so those are the specific differences, and it just is a nomenclature. When you're talking to your surgeons and your GI people, you want to make sure you're talking their language, and so it's nice to use those terms when you're writing your report. Does that make sense? Does that clear that up? Good. Okay. Now let's see. I think I have a couple more cases. Let's see what we can get to. All right. So here is an older patient. This is an incidental finding. Okay, so this patient is not having any symptoms at all. Okay, so let me show you. This is going to be a splenic case.
I think Dr. Gardner is having trouble with the connection, so we just have to wait.
Oh, this is a spleen case. Did anyone notice what's going on? Does anyone see the spleen? So no, spleen is not here. What do we have instead? Splenules. Do you see these here? These little round guys, these is splenic tissue that's left in the left upper quadrant. This is a really neat case because the splenic tissue is also on the liver capsule here. This is a very interesting case, and one of my favorite cases that I've got. How do we know that's the splenic tissue? Well, we ended up doing an MRI, and the splenic tissue followed the exact signal, as the spleen would in all sequences. So that's how we knew. There's another thing you can do to look at splenosis to find out, to confirm that it's a splenosis. Does anybody know what the other test is? It's a nuclear medicine scan. It's called a heat-killed red blood cell scan that can be done to prove that there's splenosis. And I don't think we actually went through with that on this case because we knew, because this is a pretty classic splenosis case. You've got little splenules in the splenic fossa. This happens a lot of times in the setting of trauma. If the spleen's injured and it has broken apart, and it'll form these little mini spleens. And it can happen all over the body. I've found them in the pelvis before too. And then it can happen in the setting of splenectomy, where they leave some residual tissue behind. But this is my splenosis case. Does anyone have questions on this one? Okay. I have one more case, sort of a more kind of random. We can get through this last one. Here is a bladder. This is a bladder case. I'll just let you have that just to kind of give you a heads up. Bladder case. Does anybody see anything wrong here? Okay, yeah, tumor of the bladder. Yes, yes, yes. Good job. So yeah, we have this little, there is a enhancing lesion at the back of the bladder. So we're worried that this is a mass. This is a classic appearance of, does anyone know what kind of cancer this would be? Good job, everybody. Good. Olivia, good. Yep. TCC, exactly. So TCC, this is transitional cell carcinoma of the bladder. Are we done? Is it enough? You know, we've shown our mass in the bladder. Okay, there's a bladder mass. What do we need to do? What's the next step? There's always a next step, right? What do we need to do? We need to scrutinize the rest of the collecting system, right? Because these can be multifocal. I think it's about 20% of cases, something around that. Not that it matters, but just to know it isn't not uncommon to have another mass somewhere else in the collecting system. So we found this. Okay, that's great. They're going to go in with cystoscopy. They're going to look at it. Good, Olivia. Yes, we need to look in the ureters. We need to look in the upper tracts, right? So we're going to do that. We're going to take a really close look. I'm going to go all the way to the top. We're going to look in the renal collecting system. Let's start on this right side. We're going to look really closely at the collecting system. So we're looking at this is a urothelial lesion. So we get a look at all the places all along our urothelium. So we're going to keep going down. We're following this right ureter. And we see that, oh, check this out. Right here, there is an enhancement. There's an enhancing lesion in that ureter. And look at how you can see it's dilated. So you're kind of clued in, right? You've got hydroureter here, right? And so you come down, and sure enough, there's another lesion in the distal ureter right here. So great job, Olivia, with that. And then we follow the other one too. I'll tell you, just there wasn't anything else. It was just that. You've got a little bit of hydro. You've got that enhancing lesion in the ureter and in the bladder. So this is multifocal TCC. So good. Anyone have questions on this one? All right, well, I went over, guys. I'm sorry. But we've got through a bunch of cases. Does anybody have any questions about any of the cases we looked at? Okay.
All right, Dr. Gardner, thank you so much for showing us cases today. And I saw a few of us have a record this webinar. Please do not distribute in the YouTube or any online platform, because I have noticed that some slices have patient's information in there, and it is prohibited for us to distribute that, like a patient's name or medical record number. Keep it for yourself or your institute, but don't post it on the Facebook. I'm gonna go in and then mark that before I post it in our YouTube channel. For anyone who missed it, can watch or want to watch it again, go to the YouTube channel and look at it. I'm gonna have to edit all of those information out for the for us who have recorded this conference. Please keep it for yourself or your institute. Don't distribute in YouTube or any Facebook or anything else. And thank you, Dr. Gardner. And for next month, we will have the conference on the 4th Sunday, not the 2nd Sunday. And I sent out the flyer to you all again. And give me any comment, or I can refer that to Dr. Gardner if you want
Please.
to talk to her.
Yes, please. And it's my pleasure. Thank you, everyone, for being here and for interacting. I appreciate it.
Thank you, and see you next time.
Okay, see you.